very good. Management we have discussed. Next question. What do you think? क्या लग रहा है? Thyroid? Why do you say thyroid? Lobes, two lobes are seen. Maybe isthmus is not seen so properly. Okay, two lobes are seen and cut surface shows nodules, large nodules, follicles. Okay, very good. So, what is your diagnosis, clinical diagnosis? So, this is a total thyroidectomy specimen. Everyone agrees to it? Yes. And the thyroid is enlarged. External surface nodular, cut surface shows nodules. And clinical diagnosis? Multinodular. Okay. Yes. Questions? Complications of MNG. This row. Third row. Complications of multinodular goiter. Cardiomyopathies. Again. Donkeys. Compressive symptoms. Yes. Compressive symptoms. What are the compressive symptoms that you can expect? Coarseness, trachea, dysphagia, dyspnea, everything. Okay. It can go into toxicosis, secondary toxicosis. What is secondary toxicosis? What is the name of the disease? Plummer's disease. Very good. Okay. Malignancy. Is malignancy possible here? Yes. Which type? Follicular. Very good. Okay. Will you operate all patients of any maybe neck swelling? You come to know it is thyroid. Your junior resident got very excited. Some thyroid. So there are indications to it. Okay, compressive symptoms or cosmetic reasons. Okay, very good. Retrosternal extension or neoplastic transfer. Right? Good. What are the different types of thyroidectomies? We have discussed some. Let us just go for the sake of yes. Total thyroidectomy, you remove the entire specimen. Hemithyroidectomy.
Total thyroid.
Half.
What is
half?
One
lobe plus the isthmus. Near total. Subtotal. 8 grams. From each lobe 4 grams. And near total.
Only 4 grams.
Only 4 grams. Near total also known as. Very good. Complications of the surgery, total thyroidectomy. What all consents do you want to take before thyroidectomy?
Hematoma.
Change in voice, okay. And
Hematoma.
The important consent that you might have to do it on table if you plan to take away both his recurrent laryngeal nerves. Okay, you cannot operate without a tracheostomy. And you also, what is a very important pre-operative investigation that you need to do just for medical use purpose? Indirect laryngoscopy. Very good to see the functioning because there are occult vocal cord paralysis that should be there. You need to document that before the surgery. Right? Other complications. The most important complication other than nerve injury. Parathyroid injury would lead to hypocalcemia. Someone said bleeding. Okay, post-op. There is a patient who you did a total thyroidectomy, you did put a drain. You go in the evening around 6 p.m. There is a neck swelling. Patient is having hematoma. Very good. Okay, so it is just a hematoma. You can't really wait to call your seniors. What is the easiest thing you do? You just remove the sutures, drain them. Okay, that is the easiest thing you can do. Next specimen. What do you think? Come on, it is not that difficult. The last row. Then you see the photo on the right hand side of the screen. What do you think? What is that photograph? Is it so bad? Can you not see the skin and the nipple as well? Okay? Yes? You see so much fat around. Which other organ has so much fat inside? Adipose tissue is there. Okay, so this is a specimen of C. Again, go by the approach. If you try to identify the pathology first, you end yourself up in a soup. Okay, try to identify the organ by looking at the intricacies of it. Okay, things that unfortunately these organs don't come with a label, so you need to identify them. So have a habit of seeing these things. Okay, the nipple can be seen, the skin can be seen. Okay, and there is a cut surface which shows. What do you see? Is it just a plain specimen of breast? Antemortem, postmortem? Antemortem. But why do you think? Why was it removed? Do you see the white oval structure or growth which is there inside on the cut surface? Yes. Okay. It is a tumor, right? So the tumor is grayish, which can be seen very well with chalky white streak. What do you think? This is a specimen of carcinoma breast. Questions, easy questions. Histological types, last row. What are the histological types of carcinoma breast? Whichever cells are there that can cause cancer, what are the cells which are present in you? Cells in the duct, the cells in the lobules and the intervening tissue, right? The cells of the duct can cause ductal carcinoma. Okay, depending on how much it is invading, it can be ductal DCIS, right? Or invasive ductal carcinoma, right? Lobular, again LCIS and invasive lobular carcinoma, and intervening tissue causing tumor. Cut surface shows leafy appearance. Phylloid. Okay, phylloid is from the internal, right? What are the skin changes that you can expect clinically in a patient, and what are the reasons of those skin changes? Nipple retraction. Okay. What else? Puree orange appearance because of subdermal lymphatic involvement, right? Tethering or dimpling because of Cooper's ligament. Very good. Ulceration can be there, etc. Right? Those are the skin changes that you can expect. Different modes of spread. Most important is lymphatic. Axillary lymph nodes. I am sure it will be discussed in the case presentation in breast. Everything will be examined. Right? Hematogenous. Most common. Plexus, it goes where? Lumbar vertebra. Oh, everything starts with lumbar vertebra, long bones, liver, lungs. Okay, these are the common cases of hematogenous spread in a case of CA breast. Right? TNM staging. Let us T1, T2, T3 is easy because we know it's a solid tumor. Okay, that the T depends on the size of the tumor. Right? And if there is a hollow viscous, the T will depend on the depth of invasion. Very good. T4 is very important. T4 A, B, C, D. A, chest wall involvement. What will you call a chest wall? Pectoralis major, minor. Would it change the shape? This is very important. Please guys. Okay. T4A, pectoralis major, minor. The muscle involvement won't really change the T stage. Okay. So which muscles are we really talking about? So that is anterior ribs, right? Intercostal muscles. Okay. T4B. Skin changes, again, tethering, dimpling, would it change the stage? No. So what will? Puree ulceration, satellite nodes. Okay, T4B, C, A plus B, D, inflammatory carcinoma, where? TNM staging done? Again, your favorite specimen, can't miss. Okay, this is an appendix. Okay, the most chosen specimen when given an option, right? Who will choose anything else than appendix? Okay, so this is it appears elementary because of surface hyperemic ulcerations can be seen. This is a very cute appendix. Yes. Why appendix? We have discussed etiology of acute appendicitis. Bacterial infection, luminal obstruction due to tumors, Trichobezoar. Okay, ascaris. Okay, that can also be a very important cause for acute appendicitis, right? Sequelae, the most important sequelae that the surgeons don't want to happen.
Appendicular lump, appendicular abscess.
No. Resolution. Yeah. You don't. The surgeon doesn't want it to resolve, right? For monitoring purpose, for operative purpose. Anyway. Okay. So resolution mostly. Then appendicular lump. It can be perforation, gangrene, septicemia. You have that. of sequels. Okay, what do you think? Which specimen? Again, which organ? Stepwise approach. Stomach, very good. Which surface? Antemortem, postmortem? So we have 5 minutes here. This is important thing. Let me just zoom on something. This part? There's no point. What is this? Okay, it seems like an ulcer, punched out edges. Okay, the mucosal rugae you can see going outside as spokes. Okay, so this is probably a which ulcer? Peptic ulcer, benign one. Why not malignant? It is not everted. The edges are mostly everted in benign malignant ulcers. Okay, so again, antemortem, postmortem. Would you like to change now? Obviously, it's a postmortem. You won't do total gastrectomy for benign ulcer, right? We have discussed why is this benign, factors for development of ulcer, NSAIDs, alcohol, H. pylori, complications, perforation, hemorrhage, right? If it cicatrizes, it can cause stenosis, gastric arterial obstruction. This one, organ, bowel, yeah, maybe jejunum, ileum, more likely jejunum. Seems like jejunum. Yes. But the pathology seems to be of stricture, which could be secondary to TB, which is common in. Okay. Yes. So tubercular stricture, keep it easy. It's a small bowel which has a stricture. Okay, which could be probably stricture. Okay, let us just look at the specimens. Okay, what do you think? A large fat lobule, like very good. Okay, there is no particular organ here. This is obviously an antemortem specimen. This, Jolly, 5 seconds, 4, 3. Up. Something which is zoomed in, which was not zoomed here. If you see here, which fits here?
Kidneys.
Okay, it's a kidney stone, staghorn calculus. Okay, so again it is a postmortem specimen. Okay, this specimen organ, fast. Again, adipose tissue, so many adipose tissue, there is a growth in the center. Come on, you cannot miss it now. So if I even don't show you the skin, okay, it's a specimen of breast. Okay, this it's again a thyroid specimen, multinodular goitre. This, which can be confused with thyroid. Lymph node. Okay. Is it really the height of your nose? Okay, if you see it is very well circumscribed, a benign tumor, it's a fibroadenoma. Okay, you can see the adipose tissue here. Okay, this perforated small bowel, maybe because of TB, right? You can even see strictures here, right? And you can see the tubercles on the serosal surface. Okay, this again an intestine. You can see something projecting out, right? It appears to be a polyp. Very good. Is it written? Is that the diagnosis? Again, there was a specimen which was there just behind it. The photograph was taken in a way that it seemed that this is the label of the specimen. If you can see, there's a specimen just behind it which was the tested. But see this specimen, again, partial penectomy. Can you see the penis here? Okay, and the growth. The skin is seen. This one, a colon, large lumen, and a growth. Okay, cecal growth, maybe. And this one, a very specific or very special one. Trichobezoar. Very good. Okay, so this is a Trichobezoar specimen. This Okay. So thank you. Okay. So thank you so much, guys. It was so nice to have a great audience, and we have some very good case presentations coming up. So please embrace yourself.